The next talk is something a little bit different on the other spectrum. We have an orthopedic oncologist here today to talk about limb lengthening. This is Dr. Zuckerman. He's from the City of Hope, which I just love the name, City of Hope. Dr. Zuckerman's an orthopedic surgeon and associate clinical professor, Division of Orthopedic Surgery, Department of Surgery, and City of Hope. So thanks so much for speaking with us today.
Okay, thank you very much for the opportunity. It's an honor to be here. I'm going to talk to you a little bit about limb lengthening, but that's sort of just a general term. We're going to talk about forming bone. In general, it's limb lengthening. So we're lengthening bones, but we're forming bone so that we're providing more bone for the patient. And what this is basically just a different option. And I think what's exciting about all these talks is that there are more and more options of how we can treat patients. A couple of disclaimers about this. First of all, this is something that me and a couple of people around the country and around the world, a few select people are doing. So you may not have every orthopedic oncologist doing this at this point. It's becoming more and more, but it is sort of an innovative treatment. There are some other orthopedic surgeons who do this, who specialize in trauma or limb deformity. If you are interested in seeing one of those people, I would still consult with an orthopedic oncologist because they don't understand the tumor aspect of it. They don't understand the orthopedic oncology part of it. And it's very important to get their opinion of whether these things are meant for you and whether these things are safe. In addition to that, I'm going to show a couple of things that are off-label use. And I am a consultant for the company, so take that into account with everything that I'm saying. So in terms of limb salvage surgery, and we're going to focus on bone, we can save people's arms or legs in 90 to 95% of the time. The question is that the right answer for each person? And how functional can we make the person? Now, 40, 50 years ago, the standard was to get an amputation. As soon as you came in, even if you had something in the foot, they may cut off your leg at the hip. That has come a long, long way. There's still a lot of improvements that we can do because we still have complications. Things aren't perfect in terms of what we have, but we are progressing to where we can save people's joints, which is important, and we can correct the problems that we have with some of these treatments that we have for people, and that's sort of what I'm going to focus on. These are some of the treatments that are a little more standard, that have been around a little bit longer. On the far left there, that's an intercalary replacement. Basically, we're taking out a section of the bone and we're replacing it with metal, and it's fixed with cement. They can have a high rate of failure. They sort of loosen over time. They can get infected because it's a lot of metal. Next to that is a total femur. The whole femur has been replaced. This was a growing prosthesis. There is another growing prosthesis on the market. That's basically, you would put an electromagnet around the person's leg and the implant could expand without making another incision. This particular implant had a lot of problems, so it's not typically used anymore. Next to that is an allograft reconstruction. So there's some donated bone between that plate and screws down at the bottom by the knee. And those can work, but they have a problem healing to other people's bone. They can wear out over time, things like that, break. And then on the far right is something that we typically don't use in tumor surgery, but has been used. It's an external fixator. So it's got pins and rods that go through the skin, and it's this big clunky thing on the outside. But these work really well for correcting deformities. So if someone has bow legs that are really bad, or they're really badly knock-kneed or things like that, this can be used to do that. And it can also be used to grow bone, and that was the original treatment for this. So this is the implant, and thank you to NuVasive Specialized Orthopedics for helping sponsor this event. They're at the booth, so anything that I say, you can go clarify with them. There's also a website that you can look at. So I'm going to briefly go over what these nails do. The rod or nail goes inside the bone, and it's got a magnet in it that powers a motor. So the person takes this little external magnet, puts it on their leg, arm a couple times a day for a couple minutes, and it moves up to about 1 millimeter a day. And what that is doing is tricking the body into thinking that they have a broken bone. So we cut the bone and then we slowly move it. And the body thinks that it's got a broken bone. So what does it do? It forms new bone. So as you're slowly lengthening the bone out, it's forming new bone right in that gap. And so we lengthen people's legs with that. And that's basically a telescoping rod. So it can go back and forth, it can compress, it can expand. And that's what we use for growing bone. On the bottom right is a bone transport nail, which is not quite on the market, but it has been used. It's probably, hopefully on the market next year. But basically that works by having a track in the nail where a screw can pull down the bone and you can fill in a defect as opposed to just lengthening the bone. So we have lots of options on how to grow bone. So we're going to start with just two simple cases of how we use these with just resecting the tumor and reconstructing. So this isn't a humerus, someone's arm, shoulder at the top, elbow at the bottom. We got a tumor with that dark spot in the middle. They're wearing a splint because it's starting to crack. So we take out the tumor and we actually shorten the arm. And we can shorten someone's arm or leg a certain amount and it can be tolerated. Put that rod in there, it's basically got the break, and then we slowly lengthen it out. And we can see on the far right that the person has formed bone. So we took out the tumor, we shortened the arm, and then we re-lengthened the arm so the person's arm goes back to the same length. They've got their own bone in there. And instead of having a big metal replacement or donated bone or things like that, it has a blood supply, it's less risk of breaking, less risk of getting infected, all these things that can be advantageous for it. This is an example of using the bone transport nail. So on the left is the before surgery images, that dark area in the thigh bone, the femur, is where the tumor is. So we take that out. In that third image, we cut the bone up closer to the hip joint. We got a screw in that segment that we're going to move, and we slowly move that segment down into that big defect that we have. And on the far right, we see the bone forming at the top. As we go, as it's getting closer to healing, we have all this new bone at the top where it's formed, and then we're going to dock it to that bottom part, and we're going to basically recreate the person's femur. So again, that has the advantages of it's the person's own bone, less risk of breaking, less risk of wear, less risk of infection, all these things that can work. But let's get into what happens if we're treating a cancer and we're using some other treatments. Can we solve these problems now with some of these things? So this is one thing that some people would say, well, reconstruct this, don't reconstruct this. It's very debatable. It's still debated in the orthopedic oncology community. But basically, outcome-wise, people can do very well if we take out half their pelvis. They can still walk. Many people can walk without a limp. Not everybody. Some people can't walk at all. It depends. But by not reconstructing it, we don't have a huge risk of infection or failure. We haven't really figured out how to replace a pelvis very well. So in this case, this person was walking around with a large shoe lift, and we can see that half the pelvis on that left side of the image has been taken out, and the hip bone is migrated. Didn't have pain, but had to wear about a 6 centimeter shoe lift. And we can see here at the x-rays at the knees, the knee joints are off, and this is a little bit off in terms of measurements, but we can see the huge difference between the height of the knees there. So this person has a very big limp if they're walking without that shoe lift. So what do? Well, we cut the bone, we put this rod in, and we slowly lengthen the leg out. And so then what can happen is we get rid of the shoe lift, we get the knees at the same height as seen on the left image, and after we take out the rod, we basically have a normal bone. And what this does is it enables someone to not have a large shoe lift. They can walk normally with regular shoes. Cosmetically, it helps, but also you don't want to have to wear a shoe lift 24 hours a day, right? So when you're at home and you don't want to wear this shoe, you're not having to arch your back, hurt your knees, other things like this. We can make people's legs the same length. So that's the simple answer of using this nail. We're going to get a little more complex. So here's someone who also had their pelvis taken out, but one thing that we sometimes do, not as many people do it anymore, is we fuse the bones together at the pelvis so that at least the leg isn't too much shorter. You know, if we don't do this, then the leg shortens a lot more. The problem with this, as you can see, is there isn't much motion. That's with the patient moving the leg from side to side. The left is then moving it in towards the other leg, and the right is moving out. And even at rest, the way this bone healed, it was more into the side. So they sort of walked with their knees sort of hitting together. So in that case, we can correct the deformity. And they also still had about a 4 centimeter limb length discrepancy. So we cut the bone at the top to correct the deformity to straighten the leg out more. So at rest, the person's leg is more straight. It isn't scissoring, as we call it, or knock-kneed. And then again, we cut the bone, we slowly lengthen it out, we take that out, and then here's what we got between before and after. And we can see the difference of the angle of the leg. We've straightened that out, as well as the knee heights are now normal. The person doesn't wear a shoe lift. They get around better. They have less pain. Okay, what about if we do a replacement? Now, this patient was sent to me after they had about 4 or 5 revisions of their replacements, because there can be problems with replacements. So they had a hip replacement, but because of all the surgeries that they had to do, their thigh bone, their femur actually was shortened significantly. Now, traditionally, the thought, when I was training as well, you can't lengthen someone's leg more than about 5 centimeters. And in those cases, especially in kids, you would have to do an amputation, or we say that we do it because the amount of surgeries, the risk of complications with trying to lengthen the leg are big. So in this case, what are we going to do? We have the implant there on the left. We don't have much bone in the thigh bone. There's actually probably a small little benign tumor at the bottom of the femur there that we don't necessarily want to touch. And you can see, again, those knee heights significantly different. And this person actually had about a 10 to 11 centimeter difference in their legs. So in this case, we can lengthen the shin bone. Now, the shin bone has a little bit of less of a tolerance. So this is done in stages. So on the left here, that's the beginning where they were actually lengthened 5 centimeters, so about half of what they've got. Then we wait about a year, and on the right, after the bone is healed, after their nerves and blood vessels and everything are used to the extra length, now we go ahead and lengthen them out, and they're in the process of getting the rest of this lengthened. But we can see the 2 differences. Again, we have to look at the ankles for this because we've lengthened the shin bone. On the left, there's about an 11 centimeter difference, and on the right, we've got that down to about a 6 centimeter difference. So if we can get this person's legs about the same difference, that's a huge amount of height difference that we've got. Get rid of that shoe, get around easier, less risk of tripping on such a large shoe lift, problems like that, be able to get around better. So this one, we're going to go through a little more detail. And so this patient had a pretty big sarcoma of their thigh, and the MRI shows that we're taking out a significant amount of bone. So we're going to cause 2 problems. We're probably going to stop this person from growing. We might be able to save their growth plate, but there's that risk. And then we're replacing a significant amount of their bone if we're using metal. So we could either use donated bone or we could use metal. If we use donated bone, risk of it not healing. If we use metal, we're replacing the knee, and then we're at risk for having to replace the hip later. So in this case, I used one of these nails to squish the bones together, because the biggest thing with donated bone is you need to get the compression, and you can actually get more compression and more uniform compression with these versus traditional plates. So we have a large donated bone there, and this goes on to heal uneventfully, but because we shut down that growth plate down at the knee, the person develops a limb length discrepancy. The leg is shorter by, again, about 5 to 6 centimeters. So what we do is we use the same nail. We cut around the nail through the bone, and then we slowly lengthen it. And over time, that new bone heals. It even seems to incorporate that donated bone even better. And then at the end, we have, again, symmetric leg lengths, and we've lengthened the person about 6 centimeters. And what I want to say, just this is an aside, this is how much better sometimes this donated bone incorporates. And we can see that the junction between the donated bone, there's a huge amount of the person's own bone forming around that donated bone, which typically doesn't happen with plates. Usually it's just a millimeter of tour growth. And that's sort of the problem with using donated bone, is it doesn't always heal very well. It doesn't get a blood supply and problems like that. So here is a patient who had a plate. This was for a Ewing sarcoma. And again, this is where the tumor is. Take it out. The donated bone goes from about here to about here. Both sides were healed, but this is sometimes what we see here on this picture is we still see a line there. It doesn't seem to incorporate as well. But one other problem that we get in plates with kids that are growing is they can actually disrupt the growth. Because we're sort of disrupting the blood supply, we're putting pressure on one side. bone responds to pressure. So we put pressure on one side of the bone, and what you can see here is this looks a little curved, this looks a little bit going up like that. So we've actually created a deformity. The patient's become more knock-kneed, their knee has gone up. So it's a problem with how they grew after we reconstructed them. So in that case, again, we can use one of these rods, and similar thing, because we disrupted how the bone was growing, the leg was shorter. So we straighten out the bone with the rod, and then we slowly lengthen it. And so what we can see here, the before image here on the left, where the patient is very knock-kneed, and they're definitely shorter down here at the ankle and the knees. We can see that. So we straighten that out. This is during the lengthening. So now we've got a straight bone going up and down, less risk of arthritis in the future, less problems with knocking the knees while walking. And then over time, again, the bone heals very well. And we can actually see that that donated bone has, again, incorporated much better by actually stimulating it with this bone growth. So what about this? This patient was sent to me after they had, again, an allograft reconstruction. This is a little more traditional. It's a little bit different. Some people do this, some people don't. But we can see this is where the bone is up here, and it went down to here. This is bone cement. That's why it's white in the middle there. Some people do that to prevent the donated bone from cracking, and they put a little rod in there as well. We see two plates down at the bottom, two plates holding the donated bone up at the top, as well as a plate up here. This is a screw that compresses the thing together. So a lot of things to get this bone to heal together. Now, the problem with that is you've got all this rigid stuff, and then you've got weak points. We call them stress risers, basically. So what ended up happening is they were just playing with their sibling, and the sibling landed on their leg, and they cracked through the donated bone right there. Problem with the shin bone, the tibia, is that if you crack the bone through donated bone, it does not heal very well. So we could do other things. We could try getting it to heal. We could take the fibula, the small bone with a blood vessel, and put it there to try to get it to heal. In this case, what we decided to do was to use that bone transport nail and to recreate the person's bone. So this defect, basically from here to here, is where that donated bone was. That's a 22 centimeter defect. That's a long defect that takes a long time to heal. But if we do this, it gets the home patient's bone. These nails don't always have a track where the screw can go through all the way up and down, because it would be too weak and it would fall apart. So in this case, we're using a little cable there to pull this bone up. So we've cut the bone down here, cable is through this bone here, and we're pulling it up. As soon as we get to the point that we can use a screw, we replace that cable with the screw. We can see this sort of white wispy stuff here. That's the new bone forming, and we keep going up. As it gets toward the top, we switch to 2 screws, and we're putting that up into the top there until it docks and get that to heal. Now, last case here, this is a little bit more complicated and sort of questionable what to do in this case, because again, this is a kid who was using one of the growing implants, and this had worked pretty well, but it hadn't grown as far as it needed to for how much the kid grew. And the other problem is that over time, these things weren't really meant to stay for adults, so they loosen or they have other problems. So in this case, we do have a good amount of bone left here, but if we look on the side view, it's not very good bone. So as the person was walking and this thing loosened, or as they grew, the bone can continue to grow, and it basically expanded around this implant. So there are some things, you know, to get an adult implant in here, it's going to be a little difficult. We're probably going to have to cut the bone to about there, pack it in with some donated bone, and we'll have a little stem or something else that'll go a very short distance. So the problem with that is, well, is that going to work? It may or may not work. Probably can get it to work, but how long is it going to last? And if it fails again, then what are we going to do? And this means that the kid, you know, as they now are an adult, 5, 10, 15, 20 years, whatever it might be, they may be looking at having to have their whole femur replaced, a total femur replacement. And those have their own problems. Anytime we replace a joint, it's more of a problem than if we can save the joint. Anytime we have more metal, it's more of a problem, because there's a risk of infection, there's more things to fail. When you do a full femur replacement, the hip can pop out of place, it can dislocate, other things can wear. So there are things that we ideally don't want to do. And then again, this kid, this patient had about 4 centimeters where this thing had not gone. So what are we going to do in this case? Well, in this case, we're going to try to give the patient more bone so that If he does have a problem, 10, 15, 20 years, we have more bone to work with. And then we're also going to correct that 4-centimeter defect so that we can get his legs the same length. So in this case, what we do is we put in this adult replacement. It's got a long stem that goes up here. We fix that with a couple screws so it's fixed into the bone. We take one of these rods. The rod is actually outside the bone. We fix it with a cable to the little piece of bone that we're going to transport. And what we're doing now is we're pulling that bone down over this rod, so it's got a guide where it's going. This rod has little grit blasted to it so that ideally the bone will heal to it at some point. And we bring that down and we've got all this new bone formation. So in this case, we've recreated about 8 centimeters of bone, but probably about 12 to 15 centimeters of functional bone that we can use in this case. So we've got all this extra bone so that worst case, if this implant fails later, we can take this out and we still have something to work with. Okay, now we've got to solve the problem of one leg being longer than the other. So in this case, now what we do is we take out those screws so this rod can actually slide up and down or move down as a guide. We cut that bone, and again, we take this cable and we basically are moving that bone down along with the rod. So everything is moving. This whole rod will go down and then we'll form new bone here, and we're going to correct his limb length discrepancy and get him to be able to wear regular shoes and get around. So in general, I think what's exciting about what we've got in terms of bone tumors is a couple things. One, more companies are showing a little more interest in this. That's part of the problem, is a lot of the implants were developed 20, 30 years ago with no significant improvements, but there are a couple of companies now that are interested and wanting to help with these sort of problems. There are more physicians that are interested in correcting limb length discrepancies and limb deformities, so that field is growing. It was a very small field about 10 to 15 years ago, and now there's a whole society and that is recognized by our Orthopedic Academy. And so we have more options. Again, this may not be the right option for every patient, but it gives us options. And if another option is taken, well, we can fix the problems with some of those options. And with that, I'll end my talk. And any questions?
If anyone has any questions, I'll bring the mic over. Brittany, I'll come to you first.
Hello, how long is about how long is the recovering process for, some of the things like this? It looks pretty extensive, so I just wanted to know.
Yeah, it depends on the bone. It depends on how the person heals. It depends on chemotherapy, if they're on that, and it depends on the distance. So for the thigh bone, sort of standard is about 1 millimeter a day that we can move. So if you've got a 5 centimeter defect, you're going 50 days of transport. There's usually a week or two where we sort of let the body recover, start to heal before we start that transport. And then it would take between 6 weeks to 3 months for the bone to fully become solid. And during that time, people usually have to stay off of it. These are not these are not implants where people can put weight on. So for a 5 centimeter defect, you're looking at about 3 to 4 months of this sort of process. If they're on chemotherapy, interestingly, I've seen both. I've seen the bone regeneration take longer or be quicker. And it sometimes depends on the drug, it depends on the age of the patient, things like that. The shin bone, that was a very long transport, 22 centimeters. So that's what, 200, I can't do the math right now, but that's 220 days. So that's a very long transport. And the tibia usually is a little bit shorter. We usually go somewhere either half a millimeter to 3/4 of a millimeter a day. So that's a long process. And that's the thing, is you gotta take into account, well, what is going to work this should work long term. And that's what I tell people is it's a longer process, but it should work long term. It's more likely to work than to try to revise it or have something, but those things may work in the short term. So that's sort of what we got to take into account. And that's why it's an option, but it's questionable which is the right answer. Yeah.
So I'm glad you included children with sarcoma because that was going to be my concern about bone sarcomas. And you covered part of my question, which was the effect of other treatments on it, such as chemotherapy, but often radiation is also used. Is there an issue with these other types of treatment? And are there restrictions on what the child can do while this process is recovering?
Right. So in terms of radiation, as an orthopedic surgeon, we like radiation, we hate radiation because it helps kill the cancer, but it does cause problems with most things that we do, right? So if you radiate an area before surgery, it's more likely to cause problems with the surgery than if you radiate afterwards. That's a general thing. But if you radiate afterwards, it can cause more side effects like swelling and all these other problems with it. So in terms of the donated bone, if you radiate before surgery, the donated bone is unlikely to heal. So more likely you're going to do a replacement. There are some orthopedic oncologists that hate replacements, that they say, I'd rather, someone get an amputation as a kid than, have a rotation plasty or different things like that than do a replacement because they fail. At some point they're going to fail and we have to redo them. And how many surgeries are we going to put these kids through? The thing with the replacement though, or the donated bone, especially the replacement, is they get the person up and walking quickly. Donated bone, you have to wait for it to heal. Doing the bone transport, creating the bone, you have to wait for it to heal. We don't have a lot of data in terms of radiation and the bone regeneration, but the data that's out there, there's a lot in the ENT literature where they recreate the jawbone by doing a similar process and stuff like that. And it seems to work. It just takes more time. And it makes sense because now you're bringing in a blood supply with bone, healthy bone outside of that radiated field and now doing better with it. So in theory, if you're using a person's own bone, it's going to be less risk to crack or have other problems with that. And long term, it's going to do better in terms of you don't have to worry about it wearing out. But we don't have a lot of data on that. I've done it in people who have radiation and I haven't had a problem, but I've only done it probably in 1 or 2 patients with radiation.